Thank you very much for this wonderful session. We will save the questions for when we finish, and it is my pleasure to present the next presentation, Outcomes of Corneal Transplantation to Treat Aniridia-Associated Keratopathy, the long-term outcomes from UK Transplant Registry that will be performed by Professor Francisco Figueiredo.
Thank you. Thanks very much. Thanks for the invitation. Then I'm not going to take time to explain the UK Transplant Registry because Branca has taken time to explain the Swedish one, and it's a very similar setup. It's not designed for aniridia, it's designed for all corneal transplantation. And then obviously there is a limitation. You're going to see the limitation because I'm going to share with you. And then, the conclusions are very similar to an extent. Okay, I mean, I have no financial interest to declare. Then obviously these is things that we talk about. And then I think it's highlight the point that it's a panocular disease, any bilateral and congenital, in a way that's not only the cornea. We have to take consideration the other parts of the eye, especially like Dominic has highlighted, the macular hypoplasia. Then this patient has a lot of other problems that affect the eye. Then I have to think about that. And then it's a highly prevalent disease. The incidence and severity increases with age. And then we've been discussing this already quite a lot over the whole morning. Early stage AAK is mainly medical, as Branca has highlighted, and the medical management, there are lots of things that we can do to try to maximize the treatment, to try to possibly arrest progression, delay progression as much as we can. With time, AAK will get worse, as has been highlighted, and corneal surgery may have to be considered. But as Berit has highlighted, and Per, none of them work. Advanced corneal surgery has been highlighted again by all of them. Then there is always a little bit of overlap between the talks. And I think, these, highlighted in blue at the bottom these raise the question regarding where is the evidence that corneal transplantation is recommended to treat, we call AAK, associate, not relate, keratopathy. Then, obviously, as we have the registry in the UK, we are all entitled to put an application to the registry to extract some data out. And like I said, it's a broad spectrum registry for corneal transplantation. Then I'm going to extract only the aniridia. And I have to say, that's what we aim for, and then try to get the results as much as we can. But I didn't have a clue how many corneal transplantation has been done in the UK over the last 20 years, because the registry in the UK is similar time. And then the data was collected from 1st of April 2000 to 31st of March 2001. And the data was extracted from the database in June 2022. And then obviously outcome measures considered were graft survival, best corrected visual acuity, means of correction for the operating eye, type of rejection, and cause of failure. Some statistics were used to describe patient transplant and outcome demographics. And I'm going to see that we have to adapt the statistics because a lot of the data, although we have a fixed number of people, because the rules in the UK is that every single corneal transplant has to be registered. Then we know how many patients had aniridia keratopathy, had corneal transplantation in the UK. That is not a choice. That's an obligatory, it's a mandatory. But follow-up data is not obliged. But most people do send them the data because this data is used for appraisal and revalidation. And then it's quite a lot of pressure over the last few years, but not at the time of this beginning of the registry. And then Kaplan-Meier for graft survival estimate was used. And then it's very interesting that didn't go through. Yeah, it's very interesting that you can see the number of grafts that was done over the years, and then as being highlighted in the Swedish registry, over the last few years, there is a trend of change because there is much more awareness of the limbal stem cell problem of these patients. And then people start reducing doing corneal transplantation and trying to tackle the limbal stem cell problem. And it's interesting in the UK, in 2019-20 was the highest level of penetrative keratopathy that was done in the UK over the last 20 years. But on average, it's like 2 or 3 grafts per year done for AAK. And on that particular year was 7. Then you have to take consideration the presence of glaucoma was quite prevalent, although it was not significantly higher than those without glaucoma, because 53% had glaucoma. Preoperative best corrected visual acuity for most AAK patients was counting finger worse. And this is very important because we're going to compare with the data. Again, we only have 1 and 2 years follow-up similar, And then it's a big question why we should not try to get more data. In terms of vascularization, 53 patients, 87. In total, have 65 patients. I think we kind of possibly missed one of these slides. In total, had 65 patients with aniridia. And this was a surprise to me when I saw the number, because I was never expecting to have 65 patients in the UK that had any form of transplantation to the cornea in a patient with aniridia, when you know for sure that there is the survival rate of these grafts not supposed to be very good. And then out of these 65, we didn't have the data, follow-up data. We had the pre-op data, but we didn't have follow-up data for 19, in a way that we had only analyzed 46 patients. But a lot of this data is pre-op, then is the whole number, 65 is included. In terms of vascularization, I mentioned this before, and these just highlight, again, I mean, the majority of the patient was female. Like I said, I missed one of these slides. Majority of the patient was female. Majority of patients, 95%, was white patients. Mean age was around 50, and then best corrected visual pre-op, like I said, the majority of them, 76%, was counter finger or worse. The highest proportion of AAK patients that underwent corneal transplantation was observed to have their first graft, and then 60%. And PKP and DALK was the most predominant operation. Most cases had the consultant perform the operation because these are more complicated cases. And then there was no procedure done at the time of the corneal transplantation. It was purely done, the corneal transplantation of this patient. There was no operation complication at the time. The 3 AAK patients in this registry had stem cell transplantation prior to the corneal transplantation, only 3. But we do not know the data after the stem cell transplantation. If they had corneal transplant, if the corneal transplant failed, unfortunately, is one of the gaps on the database. Then among the AAK patients with follow-up data, 46, like I said, there were 9% that had graft rejection, primarily due to endothelial rejection. And 20% graft had failed at 1 year post-corneal transplantation, 7 at 2 years. After excluding the 19 cases, like I said, that we had no follow-up data, 1 year graft survival for this patient was 73%, and 2 years was 62%. Again, this comes to me as a surprise. It's like Per said, you get these long surviving corneal grafts. I cannot explain how, because if you think this patient has severe stem cell deficiency, especially because most of the patients, that's another photo of the system, as it's not an aniridia, we don't have a clue what stage of aniridia they had pre-op. If they're stage 3, 4, 5. But I can imagine that most of them were severe, probably 4 or 5. Best corrected visual acuity was progressively worse as years post-corneal transplantation increased, with 46% and 48% more AK patients having counter-finger vision at 1 and 2 years respectively. And there's the graft survival that I just highlighted for you. Then you can see the 2 years in yellow, and then a 1 year in purple, and then 73% for the 1 year and 62% for the 2 years. Surprise, surprise, but that's the data. Then conclusion. Obviously, like I said, this real-world data, then the corneal surgeons submit the data to NHSBT, and then we explore the characteristics of AAK transplant recipients in the UK. This was the idea, just to share with you. Significant, not only here but internationally. Significant number, like 29%. We had no follow-up data. How best to tackle that? Then we've been discussed this before, and then I don't think we have a solution. In the UK, because we don't send any letters, remind them to submit the data if they don't submit the data, because not obliged by law. The number of cases in the UK every year is very small. Like I said, 2 or 3 with the exception of a few years, include the last one. And so this limited type of analysis that can be undertaken. Then the statistician had a lot of difficulties to analyze the data because the data is small. The condition predominantly impact white female, and those aged 41 to 6, around 50 as median age. This patient present with pre-op visual acuity of counting finger worse in 76%. That's quite high, the number of very poor vision. The number of corneal graft that failed and reject has smaller than expect, like I said. The 1 year survival was 73, and the 2 year survival was 62. There was no evidence of an overall difference in graft survival between donor, recipient, and transplant factor for AAK patients due to a small cohort. All rates had relatively wide confidence interval. It's no small numbers, like I said, only 7 had allo limbal stem cell transplantation, including 3 that had pre-cornea transplant stem cell transplantation, but we don't know the data for these patients in particular. Following transplantation, best corrected visual acuity was progressively worse as the years post-cornea transplantation increased. That's an important point. Visual gain post-cornea transplantation, this data was rather modest, that only 90%, a total 90% of the patient at 1 year had best corrected visual acuity exactly the same as it was pre-op. And at 2 years, 92% didn't make any difference of the visual acuity comparing to pre-op and post-op. Then that's why we've been discussing here that why you have to think carefully what's the value of this operation, because you can give these people a little bit of vision for like 3 or 4, 5, 6 months, and then the vision gets worse again. Is that what they want? Consequently, the decision to perform keratoplasty in AK patients is challenging and must be individually considered, highlighted by everybody before. Longer follow-up, like has been highlighted by Barrett and Branca, we'd like to have 2 years is very short follow-up. We'd like to have more than that. And a larger cohort is exactly. But what can you do about that? And then these are very brief summary of previous publication that has been mentioned before. These is data from Germany, and then what they did was they optimized the system and optimization. What they meant by that was small PKP 7mm, interrupt sutures, amniotic membrane transplantation at the time of the corneal transplant, larger bench contact lens, temporal lateral tracography, post-op serum drops, and systemic immunosuppression for this patient. And then if you look at the total number of grafts, again, small number-wise, only 25, group 1, 10, optimized, and group 2, 15, not optimized. And you see the 3-year graft survival is much better for the optimized one. But again, this is similar to our data to an extent. Then difficult. We didn't have any immunosuppression in any of these patients. There are complications, and their conclusion was PKP for AAK must be considered as high risk, and then be careful if you think about it. Data from Philadelphia, from Peter Leibson, and there are 2 dates, 93 and 96, that I'll share you both. 8 cases only. Conclusion, PKP as a single procedure should not be performed. Instead, it should be combined with a concomitant or previous treatment to address limbal stem cell deficiency. Later on, 2 years later, 3 years later, they published another data with 3 patients. Conclusion is exactly the same. Then PKP is not necessarily the first choice for this group of patients. And then this, again, is another study. 31 eyes of 23 patients, 20 eyes underwent subsequent PKP, 14 corneal transplant grafts were successful and 6 failed. 90.5% of 21 eyes received systemic immunosuppression. This is exactly, trying to highlight the point of the high risk for this group of patients. And then this is when came along, this data from Holland, when they did, limbal transplantation and then did immunosuppression for this patient. And they have kind of quite a substantial, reasonably good result, but they still state that PKP should not be attempted in this patient as a primary procedure. Then the message is very similar to an extent. Okay, and then this is data from Chicago, Illinois, INEA, from Ali Jalilian. And then again, conclusion, in contrast to PKP, limbal stem cell transplantation, that's the underlying pathophysiology of the AK. And then they came up with this algorithm in terms of what can you do in terms of advanced surgery, and they highlight suggesting that keratoplasty should be considered for people with grade 4 and 5, PKP, but always do the limbal stem cell transplantation. This is the data that has been shared with Barrett, and I'm not going to go through this again, but is always this business. One of the important things that we discussed before we start the session today is, I know the vision improved from hand movement to counting fingers. Is that how significant is this from the patient point of view? For what they have to go through when they have the transplantation. I know they state in the paper that is substantial, but in the registry, at least in the UK, we don't have this feedback. We don't have a clue what's the patient feeling, the personal experience for the patient, be through all that, what they gained, change vision from hand movement to count finger. I'm not sure. And then obviously question the business of all surgery. Take home message. I know you're tired, you need to have a break. But this is my last part of my talk. Aniridia is rare, congenital, panocular, like we said. Despite our increasing understanding of the genetics and pathology of this condition, it is a complex disorder, often difficult to manage. Therefore, effective treatment remains elusive. We still search for what we have to do. AAK may be secondary to limbal stem cell deficiency. We know it is, but like has been highlighted by Branka, there are so many other things on the cornea, inflammation, neurotrophic. There are so many things to account for the success rate of anything that we want to do. Then it's not purely just limbal stem cell deficiency. And then we have published data with my fellow here, Theodore, very soon about how neurotrophic this cornea can be. Not specific on aniridia, but in stem cell. Then we do stem cell transplantation, but there is a problem because the neurotrophic is important as well. Then corneal cytology and in vivo confocal microscopy provide an objective estimate of the degree of involvement of the ocular surface. The reason I'm saying that is because there's a lot of stem cell transplantation going through data in Europe now, and there is no data of impressed cytology or confocal microscopy, all based on clinical. Then you diagnose limbal stem cell failure clinically, you diagnose success clinically. And I think this is an extremely strong weakness. I strongly advise that you need to do impressed cytology, confocal microscopy, and do both, because I think this is absolutely critical and essential for your assessment, not just purely clinical judgment that is very subjective. AAK is characterized by high genetic and phenotypic variability, has been highlighted by many before. Penetrator lamellar keratopathy alone may not help, as the primary pathology is limbal stem cell deficiency. PKP has a poor prognosis because of the frequent recurrence of the same pre-graft corneal change, neurotrophic, stem cell, inflammation, followed by the subsequent failure of the graft. It has been suggested that this is most likely caused by primary abnormality on limbal stem cell of the recipient cornea. Following transplantation, best corrected VOIT was progressively worse, and I highlighted that it was most similar to the pre-op in 90 and 92% at 1 and 2 years respectively. Consequently, I would like to reiterate that this decision to perform keratopathy in AAK patients is challenging and must be individually considered. The patient needs to understand what we're doing. I know, like Per said, they want the second eye to be done. We have this every day. That's what they want. But they need to understand, because when it goes wrong, why did you do it? You knew, but they put us under pressure all the time. That's normal human being. Longer follow-up and larger cohorts are recommended for better evaluation of functional graft outcomes. That's what we've been talking about. And then long-term corneal graft, and then it's what I said, it is high risk. Why did you get good results? I don't have a clue, but has been highlighted by everybody. People have that. Then that's my next point. Why you don't try to get together the Sweden registry data, the UK registry data, and the Australian registry data, and the ECCTI registry data together, and analyze the whole aniridia data on this group? Because these, instead of being like 20 here, 30 here, 40 here, we can get a good number and may be able to do it. It's a challenge, there's a lot of politics involved on these things, lots of politics. We've been trying to do it, but it's not easy. Then in the UK, we're trying to get longer follow-up, more than 2 years. How can you chase this missing data? All these kind of things that's missing here, but it's not easy. Again, there is a lot of politics involved in these things that, unfortunately, not only scientific and medical. In patients with severe stage AAK, the stabilization and restoration of the corneal surface involves replenished limbal stem cell by means of limbal transplantation. This is quite clear by what we said before. AAK being a bilateral disease excludes autologous limbal stem cell transplantation, which are substituted by allogeneic with tissue from healthy relative, HLA match or compatible, or from cadaver. Therefore, high risk for rejection. It's very interesting that, because I do a lot of limbal stem cell transplantation, but I focus mainly on autologous. We try to get grants to do allogeneic compared with oral mucosa. Grants from everywhere in the UK. We can't afford that. It's too expensive. We have to go to Europe to get some funding. But we have Brexit. That doesn't help anybody in the UK to get money from Europe. Then is a problem. Then we have not been able to succeed on that. But we may be looking at mesenchymal stem cell, iPS cells. That's going to be presented in this next session, because we need to look at alternative, because the allogeneic and the immunosuppression is quite challenging. And then, like I say in my last point, and then Boston-Capo has been shown, but again, is very complex, very difficult, lots of complications, lots of difficulty, very challenged, very small centers doing these things in the world. Therefore, this procedure is reserved for the more advanced stage of AK, in which other forms of therapy are like to fail. my last slide. However, for a detailed understanding of the disease mechanism at the molecular, cellular, and developmental level, much work remains to be done. We have a little bit of this in the next session. Deciphering some of the key pathways and mechanisms involved in AAK can provide insights that will be important for potentially, that's why I highlight now, slowing or even arresting AAK progression in younger patients. You know, what can you do early stage to avoid being discussed what we're doing now, but also help to develop future and new therapies target AAK. And just my final line, thank you to Aniridia Sweden, Aniridia Europe, Kath Hopkins, Nikki Onuka. These are the statistician, HSBTO tag, and these are the fellows who has been involved in the project, on these projects particular, apart from John Armitage, that's not a fellow, is a friend. And then all patients that have, thank you for doing that, and Transplantation Society to provide the data. Thank you very much.
Thank you very much. In the interest of time, I would suggest that we make the questions at the coffee break. So the lesson, I think, is very difficult to learn because we still need to guide our patient through the very difficult journey of corneal transplant if we decide to do so. And we still need to learn a lot.
I think that the main lessons from this is delay as much as you can surgery, improve and customize your treatment. And in cases where we do have to do something and we know that we will be able to improve the visual acuity, then we have to improve the limbal stem deficiency. And in case we need a keratoprosthesis, normally what we do is combine it with valve surgery to control IOP and vitrectomy, and lately we are combining it in a transmucous keratoprosthesis because we know that will be difficult cases to treat.
Neil? Just one, thank you, wonderful session, and I hope we can continue some of this discussion over the coffee break. I just wanted to make one point that I think also we need to be a little bit better when we're writing in the literature about what is a success, because there's the medical success and there's the functional success, right? And I think this needs to be, you know, because it can be a little bit misleading in the literature when, you say, 60, 70% success rates, but, after 2 years, there's no improvement in vision or worse vision with immunosuppression and with all that the patient has to go through. Is that really a success or not? So, I think we need to start be thinking of more in the functional terms and in terms of the patient.
But on the other hand, for aniridia patients, vision is maybe not the leading feature of success. So we need to define first the outcomes, especially in aniridia patients, because we are trying to use visual acuity, which I don't think is the best thing to be used.
Well, maybe not the best use, but when you have light perception and you go to 120, that's a real success. And so we need to clarify, I think, I'm sure. And it's great, the presentation are really great, but I think this is a good point that underlines Neil.
Yeah, because in retinitis pigmentosa we are using different tests. So maybe we should consider for aniridia using more functional tests than visual acuity, because visual acuity is really something that it's difficult for people that are so-called normal vision, and then we have disparities there. So we may need to think about assessing visual functions in aniridia patients in the future, just to make it more a better outcome, just better outcome measure.
And even quality of life, I would say, because if you asked the patient, several years after maybe a failed transplant, if you asked them, did that vision that you gained for a short amount of time, was it worth the surgery for you? Maybe that could be an important question, because even if you will know that there will be a failure, if it's more important for the patient that they had the vision for a certain amount of time, regardless of the consequence, then that could influence the decision to operate or not.
Okay.
I think the variables are enormous. Each patient is different, then it's so difficult. And then it's amazing how many times you see a case that's not necessarily very good, but when we ask the question, come from us who did the operation, with a good relationship that we have all these patients for many years, they are kind to us saying, I'm happy, but does it mean they are happy? How can you quantify that? That's the challenge.
Okay, thank you very much.